Hi, this is Dr. Pedro Ramirez, Editor-in-Chief of the International Journal of Gynecological Cancer. And today I have the great pleasure of inviting back to the podcast my dear friend and colleague, Dr. Professor Luis Chiva. He's at the Cancer Center, Universidad de Navarra in Madrid, Spain. We're going to talk about this very important study. It's one of our lead articles and it's titled SUROVA Study, Global Real-World Treatment Strategies and Mortality Risk Prediction in Advanced Ovarian Cancer. Luis, it's such a pleasure again to speak with you. Thank you so much for accepting our invitation for the podcast. Thank you and your co-authors for submitting this manuscript to our journal, and we're really very excited to speak to you about the specifics of the findings.
This is my pleasure, and I want to take advantage of this opportunity to say thank you. Thank you for what you have done in this journal and your, desire of spreading the word and to sharing knowledge. Thank you.
Excellent. So, Luis, again, congratulations on the study. Very relevant and, of course, very timely. And we'll speak not only about SUROVA, but also about the recent presentation, not yet published, of the TRUST trial as well. But I wanted to start by discussing why are we still having these conversations as to what is best, primary cytoreduction versus neoadjuvant chemotherapy in the setting of advanced ovarian cancer. And some would say, don't we have enough data already that shows that there is no difference in oncologic outcomes?
Well, Pedro, thank you. The first thing I would like to say is that this has been one of the most passionate debates in gynecologic oncology over the past 15 years. The main question has been always the same. Can high-quality primary surgery with a reasonable rate of complete cytoreduction win at neoadjuvant chemotherapy? And for years, every retrospective study favored primary surgery. The curves always look better. But the first randomized trial, you remember, EORTC, CHORUS, reported similar outcomes between both strategies, although they were widely criticized. Conclusion very hard to accept. So the belief persisted that good surgery was probably superior. And then you remember that came more recent prospective trials trying, to clarify in this question. They added more complexity. Scorpion, that enrolled patients with an exceptional high tumor load, far from routine practice, and the Japanese JGC-OG trial with a low rate of primary surgery in the primary surgery arm, even after allowing a second interval debulking in the primary arm of surgical arm. So the prospective trials didn't deliver the definite answer until this moment. They did differ in populations, in the philosophy of surgery, in the tumor burden, and in the surgical aggressiveness.
If the TRUST was to be that definitive trial, and we'll speak more about it, but if it was to be that definitive trial, what was the reason that you and the colleagues that participated in the study considered that the SUROVA study was necessary?
Yeah, that's a great question. It's a great question because when we designed SUROVA study, the TRUST results, you remember that were delayed, but we knew that, they could become available at any moment. So we expected, to offer with these results a kind of definitive answer. However, we also understood that something essential. Trust represents the best case scenario, world's leading centers, highest surgical expertise. So we ask ourselves two key questions. Can a large, well-designed observational study reproduce results somehow comparable to a randomized trial or not? And equally important, how different are the outcomes obtained in an elite, trial setting compared with the reality of routine care across the globe? And there are several possibilities. Drugs could be positive, while real-world outcomes were negative. Both could be positive, or very unlikely, real-world data could show a benefit that didn't appear in the randomized environment. But in every scenario, the field needed both perspectives. So TRUST would tell us what happened under ideal conditions. In that sense, SUROVA was never intended to compete, but to complete trust. And together, these two studies provide a much more comprehensive understanding of the true impact of primary debulking versus neoadjuvant.
Excellent. So that gets us to the next question. And of course, as you mentioned, really massive observational study. Tell us a little bit more about how many centers, how many countries participated, and let's start getting into the study design, primary, secondary endpoints of the SUROVA study.
Yeah, well, SUROVA was designed as a large global observational study for evaluating world treatment patterns, surgical outcomes, is retrospective, standardized case report form with more than 400 variables per patient, centrally monitoring, predefined statistical methodology, including propensity matching score and time-dependent Cox models. The primary endpoint was overall survival at 5 years, comparing both approaches in patients with FIGO stage 3B to 4B ovarian cancer, and the secondary endpoint was progression-free survival. In terms of participation, I mean, we initially registered more than 350 patients. Finally, only 174 from 55 countries introduced data. Just to remember that 67% of the patients were operated in Europe, and 27, one out of three, underwent surgery. One of the largest and most globally representative real-world data sets ever put together in ovarian cancer.
Great. So with that, and you talked a little bit about the eligibility, but can you dive a little bit more into specifically what kind of patients were included in
Yeah.
the study?
To be honest, we mirror trust. So we include women over 18 years old diagnosed with 3B to 4B epithelial ovarian cancer that were considered fully resectable on the preoperative imaging, right? Of course, patients with good performance status, ACOG 0 to 1, and will exclude borderline, recurrent disease, non-epithelial tumors, previous chemotherapy, the typical, variables, unresectable metastases. And finally, because it's a retrospective study, I mean, the approach was done according to each center's institutional protocols and tumor board consensus based on the imaging, the performance status, the comorbidities, and the expected surgical complexity.
Excellent. And one of the things that we saw in the methodologies is something called a SUROVA risk calculator and predictor model.
Yeah.
Tell us a little bit more about that. How should we use it in real world practice?
Well, I mean, what using and statistical and under put together all the data, we construct this SUROVA risk calculator as a tool that can predict an individual patient's mortality on recurrent risk using 8 variables. Age, I mean, the most important variables: age, ECOG, FIGO stage 4, the presence of ascites, type of treatment, residual disease after surgery, postoperative complication, and PAR inhibitor use. So it allows to personalize survival estimates and offers the physician the ability to model various potential trajectories. I mean, what happens if the patient achieves complete resection? What happens if it doesn't occur? What if a complication occurs? And by exploring these alternative scenarios, we can anticipate how each factors impact in survival. I use that insight to tailor treatment, right? To individual strategy for each patient. But I mean, as we are going to show you afterwards, we exclude. I mean, it's only done with PAP with serous carcinomas and excluding Asian patients, as we are going to see later on.
Then before we get into the results, getting back to the point of the many centers that you included, and particularly considering that it's a retrospective study, how did you assure from so many centers data
Mm.
quality?
Well, this is a this is something that is very important, this question, because first of all, we are very aware that SUROVA is a retrospective study, and it cannot reach the level of monitoring, auditing, data control of trust of any other prospective randomized trial. But within this retrospective framework, we try to achieve, a good level of rigor possible. I mean, how? Well, we use, an standardized case report form, identical for all sites, with mandatory fields, predefined categories to minimize variability. All entries were centrally reviewed, and in case of any inconsistency, duplication, missing information, or ineligible criteria, we exclude a total of 177 patients. And we also applied automatic logic checks for an internal consistency rules. And then, of course, we send, many queries back to the investigators whenever we need.
Excellent. So now let's get into the results. What did the SUROVA study show? What are some of the highlights you want to bring up to the audience?
Well, this is very interesting, right? Because it's pretty similar to TRUST. I mean, the study, after analyzing over 3,286 patients, and after balancing with the propensity score with the main significant statistical variables, the overall survival was very similar. I mean, between two approaches, 67 months versus 65 months. I mean, primary versus neoadjuvant. However, we found that the real message lies in the subgroup analysis. First, we found, and we'll tell you how, in Asian patients, the outcomes clearly favor neoadjuvant chemotherapy, right? And in non-Asian patients, the survival curves cross at 24 months. The same happens at TRUST. With neoadjuvant chemotherapy was slightly better in the first part of the curves, but primary surgery offered a clear long-term advantage afterwards. This pattern was confirmed statistically through what is called a significant time by treatment interaction, showing that there is two realities during the time. I mean, in these patients, right? As in the beginning and afterwards, showing the effect of the treatment change over the time, something that like classical Cox models cannot capture unless you perform what is called the non-proportional hazard, what we did. So beyond that, I mean, the strongest determinant of survival was not the treatment strategy, but the postoperative complications. Any complication, especially greater than grade 3, reduced survival. In fact, the best outcome is the main result that we achieved were obtained in patients who had primary surgery, complete resection, and no complications. In this group, the median overall survival was not reached and was completely better. I mean, much higher. So these findings emphasize that patient selection and surgical safety are just as important as the complete resection.
Excellent. So now let's get to some of the questions from our fellows. We're going to
Okay.
start with Tommaso Meschini from the University of Insubria in Italy. And he's asking, for patients who were taken to the operating room for primary cytoreduction, but whose procedure was aborted due to extensive disease, how did you classify these patients? Were these patients included in the primary surgery, or were they later reassigned to the interval debulking group in your analysis?
Tommaso, thank you very much. I mean, you remember SUROVA is just a real-world retrospective study, no randomization at all. So the only meaningful analytic approach is as untreated framework. I mean, this means that patients whose primary debulking surgery was aborted due to unresectable disease, of course, were not classified as primary surgery. Instead, they were assigned to the interval surgery group because the first effective therapeutic intervention was chemotherapy. And to ensure and avoid, double counting, every patient had a unique identifier. Many patients, were excluded during the central data validation due to duplication or whatever. And in summary, SUROVA used a strict, consistent, as treated approach, which is the method that best reflects the real-world clinical practice in a retrospective global study.
Yeah. So, Luis, this next question, and this was an interesting finding in your study, the impact of postoperative complications and outcomes. And Mateo Lovero from Policlinico Gemelli, he's asking, considering the results of your study, seems that patients who can undergo primary surgery without a postoperative complication achieve better survival outcomes. However,
Mhm.
since information on abdominal tumor burden was not available, how much do you think this missing variable might have affected the interpretation of your findings?
Well, I agree with Mateo that, because he's absolutely right that abdominal tumor burden is a key prognostic factor in advanced ovarian cancer. But, um, Mateo is not right by saying that we don't have information, because even though we didn't include a formal centralized radiological PCI, for instance, we have an extensive information on tumor burden in this study for several complementary sources. For instance, we collected the surgeon's subjective assessment on disease volume. We recorded the predicted surgical complexity based on preoperative imaging. We consider all stage 3 or 4, I mean the stage 4 disease. We consider meticulously the exact amount of ascites, which is a surrogate of the amount of tumor burden. And in many centers, we have more than 2,000 cases with a preoperative radiologic peritoneal cancer index. Beyond that, intraoperatively, we documented both the Aleti surgical complexity score and the intraoperative PCI. And of course, we capture the most powerful surrogate of tumor burden, which is residual disease. In other words, all these variables were balanced in the propensity matching score. So yes, Mateo, tumor burden matters, but in SUROVA, even with preoperative and detailed preoperative and intraoperative assessment, the influence of these variables was smaller than the impact of postoperative complication and residual disease. So we took in account all what you are saying.
Excellent. Next question comes from Paula Mateo, and it's about your inclusion criteria. She's here at Houston Methodist, and she's asking, since low-grade ovarian cancer have such a distinct origin and clinical behavior compared to high-grade, what was the rationale for including patients with low-grade disease in your study?
Paula is absolutely right, and we were debating this, but I want to answer this very honestly. Very honestly, we decided to include low-grade serous ovarian cancer because we wanted SUROVA to mirror the design of the trust, period, no? Including the same inclusion criteria also regarding low-grade disease, right? But very interestingly, our proportion of low-grade tumors were almost identical to the reported in trust, which confirm again that the retrospective study, this retrospective study was consistent with other practices, and of course in daily clinical practice is completely right that patients with low-grade disease are more often selected for primary surgery. So to avoid imbalance, we include tumor grade in the propensity score matching. So this ensured that both treatments were properly balanced and the presence of low grade didn't distort our comparative results.
Excellent. Next question comes from Mathilde Del in Toulouse, France, and she's asking, your study, HRD status was not analyzed due to
Mm.
extensive missing data. Do you think HRD could nevertheless have influenced your results, particularly through differences in chemosensitivity? In your center today, do you manage patients with different HRD statuses the same way, or do you tailor treatment accordingly? And do you plan to evaluate HRD in the future analysis to address this potential confounder? So, a couple of questions in one question.
No, exactly. Well, this is a great point because, at the time that we collected patients, in 2018 and 19 in this study, I mean, all patients were operated in that time. HRD testing was not, available in most of the centers around the world. So this is a great point. And you may have, the hypotheses that are unbalanced. And you have in one of the arms much or more or less, BRCA mutations or whatever. But, it's the same that happening with the trust. Because at that time, because it belongs to what is very interesting is that SUROVA and trust collect patients at the same time. So in the trust, the HRD was not routinely reported. What we did is something easier, is to use the PAR inhibitor use as a surrogate marker of the presumed HRD. And what happened? That the PAR inhibitor exposure were perfectly balanced in both groups, primary and interval debulking. About the 10% of the patient had primary maintenance with PAR inhibitors, and around 20% of the whole population use PAR inhibitors in both arms at some point of the disease. So very similar proportions, that meaning that you are balanced. So we didn't had to, I mean, we had not to include this variable in the propensity score. Today, of course, we are, tailor much more precisely, probably, the treatment based on BRCA mutation, HRD status, what was not feasible at that time. So, but yes, we absolutely plan to evaluate HRD in future analysis for more complete genomic data in a near future with using these patients in future studies. Thank you.
Back to Tommy Meschini. He's asking, from your results, it appears that nearly 1 in 3 patients who underwent primary cytoreduction did not achieve R0, which is very, very consistent, I believe, with the trust, where it was R0 68%. And if we consider only those who did not experience postoperative complication, the number rises to 1 out of 2. How do you explain this finding? Could it be due to inadequate multidisciplinary evaluation of the patient?
Well, it might be possible, but I want to clarify something. I mean, because it's not exactly what Tommaso is telling us here. I want to clarify the numbers. In SUROVA, the complete resection rate in the primary surgery arm was 71%, essentially 3 out of 4 patients, not 1 out of 3. This is almost identical to the trust report, as you said, around 68%, which is remarkable considering, and we don't understand this very well, because considering that trust was a prospective study conducted in highly specialized centers. Probably it's a matter of bias for selecting patients for this study. The point is, this consistency shows the preoperative ability to predict complete resectability is limited. Even in expert hands, at least at this time or now, right now. I mean, we have the same limitation for recurrent disease. Remember, or for Fagotti score, or for the I model, or for the positive score for AGO for recurrent disease. I mean, they are achieving no 100% of accuracy for complete resection, probably 70, 76%, which so 70 is okay from my point of view. And regarding complications, unfortunately, complications doesn't reflect just poor preoperative selection only. I mean, we have perioperative and patient-related risk, and our ability to predict them beforehand is still limited. So this will certainly improve, as I imagine, and other diagnostic techniques evolve, but today this limitation is shared by all centers worldwide. But the key message is that the resectability performance in SUROVA is essentially identical to TRUST. And the challenge of predicting complete resection is universal. It's not a failure only of the multidisciplinary evaluation. But I truly believe that our humble study will help increase awareness and drive further improvement in the near future on this.
Great. Next question comes from Masha Pervin, University Hospital Münster, Germany. She's asking, how do you explain the markedly different outcomes of interval versus primary in the Asian population? Can the tumor biology really be different? Is this due to genetic, metagenetic factors, differences in practice, training in Asia, as opposed to the so-called Western world?
Well, this is for me was one of the most compelling findings, and I would be very cautious not to overinterpret, these findings. The ethnicity analysis was not pre-specified, And although the number of ASEAN patients was meaningful, if I don't remember bad, 40% over 400 patients is limited. So these results should be just considered as a hypothesis generating rather than definitive. But on the other hand, I mean, there is external evidence consistently that show better survival in ASEAN patients. Remember the recent published US National Cancer Database study with more than 37,000 patients, stage 3 and 4, finding that Asian women had a 19 lower hazard of death compared with white women. Even after adjusting, they receive primary of interval. So, I mean, the improve of outcomes in ovarian and ASEAN course has been described, even when patterns are similar, right? And talking about pharmacogenomic differences, I mean, has been mentioned as well. But you know, these vary wildly across ASEAN subgroups, different drugs, and SUROVA didn't collect genomic data. So it's very difficult, you know, to attribute, you know, the finding of these pharmacogenomics alone. I think is a little bit speculative. So in summary, we cannot conclude that the tumor biology is different, definitely different in the Asian population, but our findings, you know, open a window to understand if there is, you know, that probably we justify further prospective research, ideally incorporating molecular profiling and a more detailed analysis, of course.
And as a follow-up to that question, Mo Byrne from the Memorial Sloan Kettering Cancer Center in New York, she's asking now, do these findings change
Yeah.
your treatment recommendations for an Asian patient that comes to your hospital today?
Well, this is, yeah. Honestly, I would like, you know, to review how are the curves of these Asian patients, you know, after neoadjuvant are really impressive. But I don't think, unfortunately, that SUROVA should change clinical practice at this stage. Again, the ethnicity signal was interesting, but it was not a pre-specified analysis. Number of patients was limited. Just clearly is hypothesis generating, but no practice changing. Well, but you know, after that said, if I were, you know, to treat an Asian patient today, for instance, from India, that was, you know, the most important group, with a very significant, but potentially resectable disease burden, I mean, after looking at this, I would probably feel more comfortable using neoadjuvant chemotherapy a bit more liberally than before, given the trend we observe in SUROVA and with the very consistent data from large US database showing better survival in these women, irrespective of the treatment strategy. But I mean, I think that this hypothesis now deserves, you know, to be formally tested and validated, right? So Surova opens a door, but it doesn't close the debate, right?
Yeah. So now we go into Newfoundland, St. John, Johnny Nouveau at Memorial University Hospital of Newfoundland. She's asking, the SUROVA study shows that only patients who achieve complete resection without complications postoperatively benefit from primary surgery. How should this reshape our clinical decision making? Should fitness for surgery now be defined not only by resectability, but by the predicted likelihood of a complication-free recovery?
Wow, for me, I mean, um, Johnny, thank you very much. For me, this is probably the most important question of this discussion because Surova makes something very clear. I mean, complete resection is important, it's essential, but complete resection without complication is what truly drives survival. So, complications come from two different origins. Some are surgical or technical, related to difficulty, surgical judgment, or experience. I mean, of course, for this, training, meticulous technique, prevention, and better perioperative planning can reduce the risk. But there are other patients, other complications that are patient related. And we discovered that even grade 2 complication that has been, I mean, tested by the people from Memorial, right? By Dennis Chi. I mean, grade 2 complications that we often consider minor in SUROVA still influences survival. I mean, deep venous thrombosis, wound issues, infections. This reminds us that we must understand who is biologically fit to tolerate a major cytoreduction. Look, I mean, the numbers, they are striking. I mean, out of the 100 patients taken to primary surgery, of course, 70% achieve complete resection. But among those, 30% will still experience some type of complications. So in practical terms, someone said before, only about half of the patients we currently consider resectable truly that obtain, the full long-term survival of primary surgery. So that, point out two responsibilities. Either reduce the number of patients we take to upfront surgery, focuses only on those with the highest probability of complete resection and eventful recovery. I mean, what we say in Spanish, las peritas en dulce, I mean, the great cases, the piece of cake, or maintain current indications, but dramatically reduce complications through better prediction, frailty assessment, perioperative optimization, and improved surgical pathway. So, yes, fitness for surgery can no longer mean only resectable. This is my point of view. It must mean resectable and likely to recover without complications. SUROVA opens the door to developing a new generation of complication prediction models, which in my opinion is the field that needs to move next. And in fact, we are presenting an abstract in Copenhagen trying to define the first version of a complication predicting score using this data.
Well, that's great. And then it's a perfect segue to this next question by Matilde Del. And she's asking about how do you assess and potentially reduce the risk of such complications from your own country in Spain, Esther Miralpeix in Barcelona. She's published a lot on prehabilitation. What are your thoughts on all of this?
Yeah, well, Matilde, thank you, because this is the $1,000,000 question. I'm glad, it comes up because SUROVA tells us that reducing postoperative complications may be one of the most impactful ways to improve survival. So I foresee three major avenues. First, better patient selection. Not only resectable patients, but also patients capable of tolerating a major cytoreduction without developing complications. So we have to move forward to frailty assessment, biological fitness scores, validating prediction tools that we don't have yet fully implemented, unfortunately. Second, improving surgical quality, meticulous technique, multidisciplinary planning, more experience, concentrating the most complex cases in high volume centers, and even small improvements here can reduce complications in a meaningful way. And finally, something that Pedro Ramirez loves a lot, which is perioperative care, engaged recovery, aggressive thromboprophylaxis, infection prevention bundles, nutrition, physiological optimization. In short, complications unfortunately are not inevitable. SUROVA shows us how we must start combining patient selection, better surgery, better perioperative care, and probably, to validate complications prediction scores that can be used before surgery.
Great. And our last question from the fellows, a question you may find a bit challenging there, Luis, because of this topic and what it suggests. So she's asking, Joanny Nouveau, she's asking, if achieving complete resection at any cost no longer guarantees better outcomes, how should surgeons balance the pursuit of cytoreduction with the responsibility to minimize harm? And could the future of ovarian cancer surgery be less about maximal effort and more about strategic restraint?
Well, another incredible question that goes, to the heart of what we are discussing. And for years, ovarian cancer surgery has been driven by the idea of just maximal effort at any cost. SUROVA shows us that this is no longer enough. Its complete resection matters, but complete resection without complication is what truly transforms survival. So how do we balance benefit and harm? So we need a more strategic and patient-centered approach. This means bringing the patient directly into the decision-making process. We have to explain that we aim for the best surgical cure, the one with complete resection and no complication. We have to explain this to the patient, but that complications can occur, and that some of them depend on the patient's own biology and frailty, not only the surgeon. But there is something important. We must reassure patients that even if a complication occurs, the survival will not be worse, usually, than with neoadjuvant chemotherapy. It simply means that they lose the potential added benefit of primary surgery. I think that distinction is essential. I mean, we lose the advantage of the primary surgery, but we have probably the same result that neoadjuvant chemotherapy. So the future of ovarian cancer may indeed be less about maximal effort, maximal surgical effort, and more about a thoughtful reflection, choosing the right patient, the right moment, the right operation. And in my humble view, SUROVA marks the beginning of a more balanced, individualized, and honest era in surgical decision making.
Well, Luis, thank you. One last question. We have a new tradition in the podcast. The last question is posed by AI. And AI read your article, and this is the question that it came up with. How can the authors claim treatment-related ethnic differences when ethnicity was not pre-specified and consistently measured and highly imbalanced across centers, raising the possibility that the striking, quote, Asian benefit of neoadjuvant chemotherapy is simply an artifact of confounding pharmacogenomics speculation or center-level variation rather than a true biological effect?
Well, honestly, we agree with AI, and we fully agree that ethnicity was not a pre-specified endpoint, and it was captured with the limitations of a retrospective study. For that reason, we make no claim of a true biological or causal ethnic effect. What SUROVA shows is simply an expected statistical signal that Asian patients appear to benefit more from neoadjuvant, and this emerged only after a stratification and only because the proportional hazard assumption behaved differently in that subgroup. So, in other words, our statistician said it's impossible, to keep the ASEAN group in your analysis because they are behaving completely different. I mean, probably it's I don't know if it's due to the bad design or whatever, but this is what the statistical result. So we explicitly acknowledge that this finding may reflect a confounding differences in the case mix, the pharmacogenomic hypothesis previously described in the literature, whatever, or center level practice in those centers. Well, that is why we had to remove from the primary analysis to maintain the model validity, and when the result is presented strictly as exploratory. So in short, SUROVA doesn't claim any treatment difference. It reports an observation, openly states its limitation in the article, and encourages dedicated study to address this question properly.
Well, Luis Chiva, thank you so much. That was really a very, very enlightening experience. Always, we learn so much from you and your thoughts and your process as to how to analyze and interpret the previous literature, the current literature. You have taught us all so much throughout your career. You have had an amazing personal and professional journey in life, and we really admire and respect you for that. Thank you for all that you have contributed to our field, that you continue to contribute to the young trainees in gynecologic oncology. And again, thank you for what you have done for many, many patients with gynecological cancers. Truly an honor. And once again, thank you for your time.
Thank you, Pedro. It's for me an incredible pleasure to be always, close to you. Thank you, sir.